Shall we start? Yeah, good evening one and all. So it gives me immense pleasure in inviting Miss Anjali Kapoor, affiliated with TIRR USA. She is our esteemed alumnus of BPT 1996 batch. She went on to pursue her master's in physiotherapy with specialty on as neurological conditions from Texas Women's University. So she has been in clinical service for past 17 years, 17 plus years, and she is expert in managing patients with neurological condition. And she is also clinical coordinator for clinical education and instructors for DPT students. On behalf of HOD and faculty members of Physiotherapy MCHP, I cordially invite Ms. Anjali Kumar for the webinar session on orthotic management in the neurological population. So over to you, Ms. Anjali.
Thank you so much. Do you want to wait a few more minutes? It's still like a couple of more minutes left for the time.
Okay. Yeah, we'll wait then. We'll wait for 2 more minutes and then we will start.
Yeah, that's fine. Because I see people joining in, so I think we can just wait for a few more minutes.
Okay.
Can you all see my presentation?
No, not yet.
You thought, hold on. How do I share that?
Yeah, next to the microphone icon, you will see that small rectangle with an arrow, upward arrow.
Yes, I see it now. Okay. There we go.
Yeah, you can start.
Okay.
Over to you, Miss Anjali.
Okay. Hi, good morning or good evening, everybody, depending on what time zone you are in. I wanted to talk about orthotics because I feel like when I was in India, which was 20 years ago, we didn't talk much about it. And it was a big cultural shock for me when I started doing neurology over here. And I thought a little bit brief intro about it would be really helpful for everybody. I'm happy to answer any questions. If you have any questions later, you can email me. I think my email address is on the slideshow. So I'm happy to answer anything. It's a lot of material I try to put in there, so I might skim through some of the stuff, and some stuff I'll go more in details, okay? So my objective here is to identify gait impairments and discuss the possible causes, identify which orthotics are most appropriate for different gait deficits, and understand how to modify the AFO design base to improve the motor recovery. So what are the major problems with patients with neurological deficits? Either they have weight acceptance issues, so especially on a stroke side, and especially if they have a neglect on that side, they don't even understand to accept weight on that side. Then the single limb support, same problem because of the weight acceptance, and then also advancing the hemi side, or if it's MS, it could be both sides, depending on what muscles are weak. So before I get into all these problems, which we kind of see with all these patients, I mean, this is a list I listed here. You can go over that list. You all have seen these, you all have been there, done that. So I don't think I need to go in detail of these problems here. So I'm just going to skim through the problems that we typically see in this kind of population. But before I get in there, I would like to say, try and pick your battles on what you want to fix by giving them a brace, because we cannot fix everything, but I would try and pick up maybe a couple of major problems they're having and then try and fix that. Do realize if you're trying to fix those, you might end up losing some of the things also. But as I said, pick your battles, see what exactly they need help with. The main idea is they should be walking. So all the studies and research have shown that the more they walk, the better they get with walking. So the only way they can walk is by walking. So just think about that, and whatever will get them to walk more and walk safely, try and fix that with the brace. Also, if it helps them to weight accept and weight bear more on that side, then that's what you want to try and fix. Also remember one thing about, I know a lot of people and a lot of school of thoughts about early bracing. Some school of thoughts actually say we should not brace them early. We're trying to make their muscles weak on the side. My school of philosophy on this is that if you are trying to intricate the correct motor pattern on these patients by giving them a brace, then the brain will learn the right way of walking with the correct biomechanics. And then slowly you can take the brace away as they get muscle strength. But if they are going to be walking with, say, a foot drop and a hip circumduction for 6 months before they get some strength to not circumduct anymore, or they get some dorsiflexion strength, the problem is by then the brain has already learned that pattern for so long. It's been 6 months, and you do all know that motor learning does happen. If it has learned for so long, it is hard to break that pattern, even if they have the strength to break it. So what I believe in is, if you do early bracing or early orthotics on them, and don't let the brain even learn the wrong pattern of or the abnormal biomechanics of movement, get them to the right mechanics of movement, and then slowly trim the brace or take the brace away as appropriate or as needed. So let's go. So I have a form here, which I had attached, and I actually have an empty form at the back of my slideshow. I'm hoping Selvam sir will share the slideshow with anybody who needs it. So this way, initially, when you're trying to do bracing, I think this form was really helpful for me, because you can actually just do the full body analysis on their gait. This is actually from the Rancho Los Amigos National Rehab Center in California. If you all don't have access to this book, that's the same book that has that form. It's an amazing book for gait analysis. So initially, when you're trying to do this more in details, I think that book is really helpful, and this form is really helpful, because you can actually kind of check out what all the impairments you're seeing. And then again, you can see how on the right side it says major problems. And that way, at least you pick your battles, you know the exact things that you want to fix in this patient, and then you go from there. So this kind of helps you narrow down things with that patient, because when you see them walk, you'll see like 20 things which you want to fix, but unfortunately not everything can be fixed. So this will kind of help you narrow down what you need to do with this patient. So again, with the deficits, again, we have seen most of these, but in hip, you can see decreased extension. In knee, we either see crouch gait, which is increased flexion, or you see hyperextension. In the ankle, you can either see foot slap, flat foot contact, or forefoot contact. And then in the swing deficits, you can see hip either going in circumduction, external rotation, abduction. In knee, you can see decreased flexion. And in the ankle, you can see, if there is swing deficits in the ankle, you'll see contralateral vaulting. So where they vault on the other side to try to clear this leg. So when do we use an AFO is, If they have muscle weakness, if they have abnormal tone, if they have poor alignment, if they have decreased efficiency or endurance, decreased safety, or fall risk. And as I said, you might not be able to correct everything. Sometimes if the dynamic tone is way too much, you might not get the exact same pattern that you're looking for. But if they can walk safely and they can walk more with the brace, even if you cannot break the abnormal tone, I still think it's worth it, because at least you can get them to walk more and do more things. So the goals for having an orthotic device or a brace is to increase ambulation, to increase balance, to increase biomechanical alignment, and to manage tone. So impact on the gait cycle, I try to put the slide in. This is very variable for every patient. As we all know, like every patient is different. But the few things that I want to hit on this slide is that do remember that if the knee is hyperextension, it could be because of a lot of other reasons. It cannot just be because of, say, lack of knee extensor centric strength, which is the quad strength, but it could be because of plantar flexion weakness. It could be because of the hip going in retraction. It could be because of hip abductor or knee extensor weakness also. So think about all the things that can cause knee hyperextension. Because again, if you're just focusing on the eccentric strength or knee extensors, you might not get the whole effect if you're not focusing on the other muscle groups that we have talked about. And then for initial and mid swing, you can have decreased dorsiflexion strength, which leads to decreased foot clearance, and then they compensate with circumduction, external rotation, or abduction. One thing about AFOs, if you are fixated on trying to preserve the rockers at the ankle joint, unfortunately, solid AFOs do not maintain any rockers. The fourth rocker can be maintained if you do a flexible foot plate or trimming the back of the toe box, but I haven't seen much success with it. So do realize that if you are going to get them a solid AFO, because if that's what they really need, don't persevere on trying to maintain the rockers, because I mean, yes, going on stairs will be hard, but then again, as I said, you have to pick your battles. If you feel like stairs is their biggest goal, then yes, don't give them a solid, and then give them a hinged or give them a PLS. But if stairs is not their biggest goal, and the goal is for them to walk and just to get around and to increase their safety with walking, then just think about you're going to lose your rockers. Always consider the fact that if they have lost some range of motion, your brace cannot accommodate that. So before you cast them to get an orthotic, talk to your orthotist, see what they can do to accommodate it. Sometimes they can change the shank angle to accommodate plantar flexion contracture. They can give you a heel wedge to put in there to accommodate the contracture. Sometimes if it's a new acute case, serial casting or just giving night splints to stretch the joint before giving them a brace is also helpful. Just depending on how compliant you think they'll be at home. I work in an outpatient setting. I think it's a little different if you're inpatient, because you can do it for them. And if you're right there, you can put the night splits on them. You can make sure they're stretching, and you will definitely get better results. In outpatient, it depends a lot on how much they follow through when they go home. Sometimes they're compliant, sometimes they're not. You can try it for some time. Typically, if you give them a nice splint, you should see some good results within the next 10 days. So you could wait 10 days and see if you're seeing results or not. If you are seeing results, then it's fine to wait. But if you're not, then it's probably okay to just brace them with accommodating their range of motion deficits. So just remember the shank to vertical angle 10 to 12 degrees is the ideal for mid stance. So you never want to brace completely straighted. Always a little inclination is what you need to help with tibial advancement. And then I would recommend, if you do a lot of this, make orthotists your best friend. That's what I did initially, because they are the ones who make the brace. They understand the mechanics of this also. The best way it works is that therapists and orthotists both talk together and try to figure out what will work the best for the patient, because we have the physical therapy aspect of them. They have the aspect of making the brace. So I think it's best if you can work together as a team and then figure out what exactly you can give them. The range of motion, one more thing I would like to tell you is that R2 is not the most comfortable range for any of these patients. So I would never try to put a brace on a patient on their R2, which is like all the way to their max resistance of range of motion. R1 might be too less. So usually, typically, I do something between R1 and R2 to give them a brace. So I think I've talked about most of these things. But one thing is to validate your outcomes. We over here use a lot of standardized testing. If you need to do a test to justify to the patient or the family that why that brace was important for them, because I know we get a lot of resistance from patients and family, like, oh my God, you put a piece of plastic or piece of carbon on my foot here and I don't feel very comfortable. I would do simple tests like a 6-minute walk test where you walk them for 6 minutes pre and post and see how much difference they have made with having a brace. Initially, they will be slower because they're getting used to it, but usually, typically after 2 to 3 weeks of giving them the brace, they are faster and they are more efficient with walking. So you can justify using over here, just because the insurance companies, actually, we have to justify for the insurance to cover our AFOs. So that's how we justify by using some of these tests, which I've listed on the last line on the slide. Either a tug or a L test is typically used for amputees. 6-minute walk test, 10-meter walk test, any of those. Always, obviously, do your MMT to see exactly where the muscle deficit is. Sometime, MMT will give you a clue on what you're going to look at when you start walking them. Sometimes there's so much compensatory movement that it's hard to figure out without doing an MMT. So that will definitely help you to figure out what they really need. So as I talked about, so I'll go into little details on the kind of AFOs that we use here typically, and I'm sure you all use the similar kind over there. Any questions so far? Anybody on the things I've talked about before I get into details of kinds of AFOs?
Do any of the participants have any questions? You can just, you have a hand icon. You can just click that if you have any questions at this point of time. Okay, I think there is no questions. You can proceed.
Okay, so we can keep going. I just didn't know if people wanted to stop at this point before I go into details. So, so the kind of night splints you can use, they can be either positioning or for the positioning, they can either be a solid or they can be articulated. So typically people who have like low tone, you'll give them a solid one because their foot's not going to stay intact in an articulated one. And also, if you may see some kind of coronal plane and ankle and foot deformity, you'll give them a solid one. Articulated is typically given for patients who have high tone because again, you want to keep pushing them, but you can't take them to R2 right away. So if they're high tone, then you want to start with, say, at R1 and then slowly push them to R2. So for those, solids won't work because then you have to make a new one every single time, which is not time efficient or money efficient. So then you want to give them an articulate one because you keep pushing them into the range. This is what an articulated night split looks like. So you can see there's a joint angle, and with just a little Allen wrench, you can actually change the angle. So if you feel like the range of motion has gotten better, you just take an Allen wrench, rotate the screw on the joint you see at the ankle, and then push the ankle closer and closer towards the tibia to reduce the angle. So kind of AFOs that we use for walking. I actually did bring some of the AFOs to show you also. So this is a solid AFO. I got one here. The trim is pretty high. So if they're having a lot of, here, let me turn around so I don't see the strap. If you have a lot of medial lateral instability along with the foot drop, or as they say, triplanar deformity, then you use a solid AFO. It does promote a lot of stability in the stance phase. It does help with the clearance in the swing phase. It does control the medial lateral instability. Also, as I talked about, if there is a contracture, then you will have to accommodate that. Also, as they get stronger, then you can keep advancing it by, you can trim the lines right here. So right now, this is the ankle joint right here at the malleolus. You can trim it down and down, and you can actually, so that will help them more with a tibial advancement control and maybe preserve some rockers if you do a flexible toe plate. But if they are really weak and they are buckling on you and they have no swing clearance, I would start with something like a solid AFO, and then slowly you can start trimming it down. Again, as I said, make orthotist your best friend. They can make adjustments to these as many times as you want. As long as you tell them exactly what you need, they can do it. Okay, so the next one is a traditional ground reaction AFO. So let's see if I have it. Okay, here we go. In the ground reaction AFO, it's mainly used for knee instability. As you see, there is a little plastic piece that comes in front of the knee. So if you have a patient who crouches a lot and who cannot stand without the knee bend, then you can give one of these. It kind of promotes knee extension. It pushes the knee back. You can limit if you get too much of a push, if the knee is really weak, sometimes they will go in hyperextension. Because you're pushing it. So then you can prevent that by raising this part up more. So if you raise the back more, and so it'll prevent hyperextension, and the front will prevent buckling. So you can get a lot of knee stability with the ground reaction AFO. I try to control the knee the most with giving just a AFO. I know some patients do need KFOs. If the knee is very unstable, do realize that KFOs are not the easiest to walk in. They are really heavy because they go through two joints, and the KFO, because it has a metal joint on the knee, it's very hard to walk in. So again, as I said, if they can walk with something like this, I wouldn't give them a KFO. So I have done this in the past where I have given a ground reaction AFO to walk, which doesn't look like the best walking, but they're able to walk because we give them some knee stability. And then I've given them a KFO to stand, to just stand at home, to work on their standing tolerance and endurance, and to have a better mechanics of their knee. I mean, for somebody to walk in a KFO, they really have to be in a perfect health condition with a lot of upper extremity strength. And I've never seen, even though I have like a 25, 26-year-olds who have been like athletes and who've been in a car accidents with spinal cord injuries, it is hard to walk with a KFO without having crutches or anything upper extremity support. So they need a lot of upper extremity support to walk with the KFOs. So I wouldn't give them a KFO to walk. Just remember that because of this stiffness right in front of the knee, stairs are hard for them because they can't bend their knee, because this is actually preventing the knee to bend. Also, sit to stands are hard because they can't kind of lean forward because there's only so much the knee can lean into the brace. So sit to stands get a little hard for them, stairs get a little hard for them. But again, if you can get them walking more, and if you can get them more stable walking, then this is what they will need. The semi-solid AFO is kind of in between. I don't think I have one of these, but it's kind of in between a PLS and a solid ankle. Again, I was saying that if you take a solid and if you try to trim it out a little bit, it will help with tibial advancement a little bit more than what a solid will do, and it will be a little bit more invasive than a PLS. So the semi-solid is kind of in between a solid and a PLS, basically. They don't typically make semi-solid. They start with a solid, and then as you need to trim it, they can keep trimming it. And then the next one is a PLS or a toe-off, which I keep talking about. So a plastic PLS looks like this. Do realize it's really trimmed back, so there is no medial lateral stability provided in this. It is purely for just curing the foot if you have a foot drop. Also remember, even if they have a foot drop, if their hip flexors or knee flexors are weak, then the leg will still drag. So you have to, so one thing which I do is like if say the hip flexors, knee flexors, and the ankle dorsiflexors, everything is weak, and then there are 3 joints that you have to work on, you can give them a PLS, so you don't have to worry about the ankle for right now. So you can kind of focus on hip and knee right now, and then the foot will get cleared with this regardless. And then slowly you can take this off once you gain strength in hip and knee. And then you take this off, and then you can start working on the ankle. So it is helpful in a way where you don't have to focus on so many joints at one time. You can start with proximal joints and then slowly move towards the distal ones as time goes. But it's mainly for foot drop. This actually works really well for peripheral nerve injuries. If they literally just have a foot drop from like a nerve injury in an accident, and it's just that one leg with a foot drop, and that works. For a stroke patient and stuff, typically you'll never see a pure foot drop. There's so many more other muscles that are impaired. But as I said, if this is what they can go with, and this is what you feel like at that point is what they need, and these other joints are not that bad, you can keep working on those, and then you can take this off later. So this is a more stable PLS. It's a plastic one. It's not giving at all. There is a dynamic PLS that looks like this. So this is actually more energy giving. So if you see, if I press on it, it actually has more flexibility to it. It's made out of carbon fiber. So this actually, for my MS patients, actually this works the best. The only reason it's very lightweight as compared to the plastic one. And again, if they just need just simple assist to work on picking up their foot and walking, do realize that because there's front force on this one, it's an anterior panel, it can cause the knee going into hyperextension. So there are different models on these. So instead of it coming in the front like that, you can have something going behind. So if the hyperextension is an issue with these patients, then I wouldn't give them this, because that's going to push them more behind, and that's going to cause more problems. So there is a different model that goes, the strut goes, instead of going in the front, it goes actually behind, and you can use that instead. But this is definitely more energy giving. It actually does transmit energy from your thigh all the way to your ankle because of the flexibility and the carbon fiber that it's made of. So if you have a younger patient, these actually work great for them for helping them walk. The articulated or the hinged AFO, let me see, I think I have one of those. Okay, so that's the hinged AFO. I am honestly not a big fan of these because honestly, I don't see much difference between using these versus PLS. One thing I will tell you for a fact, if they have if they have plantar flexor weakness, if their plantar flexors are not more than, say, 1+ or 2, this is not going to work, because if you have to put a plantar flexor stop in a dorsiflexor stop, then it actually just mimics a solid. But if you have to put a stop at plantar flexors, then there is, because if they don't have enough strength to control it eccentrically, um, then it's not going to be worth using this. Uh, it is helpful in cases where you're just trying to get some quad control and you're trying to get some dorsiflexion assist. And it does preserve rockers a little bit because of the free movement that it has at the ankle. But honestly, I'm not a big fan of it. If you have any kind of quad weakness, plantar flexor weakness, it's not going to work the best as you would like. I know some patients do like that because they don't like to be restricted at their ankle for the range of motion. So some patients actually like these. Um, Typically, what I do is if they are really insisting on having some range, then I kind of put some stops. So see how this one has a stop. It doesn't even go past a certain range. Then it will still give them that sense of, oh, okay, I have some movement in my ankle. And a lot of patients have this kind of opinion saying that, oh, if I'm not going to move my ankle, then I won't get stronger. And yes, I do understand and I do realize that. And this is what I tell them is this is only to help you walk. You still take your brace off and you still exercise. You still do all the exercises that are needed to work to get that ankle or that knee stronger. This is purely just to help you walk. And tell them about all the evidence-based practice that has been out there, that the only way you can walk better is by practicing walking. So if they can walk more by putting an AFO on, and they can get stronger, because all these muscles which are used to weight bearing, which need to be weight bearing when you're walking, you can't really strengthen them by not walking. Um, you can't strengthen them in sitting. You can't strengthen them in supine because you're not weight bearing on them. And the only way you're going to strengthen them is by weight bearing on them, by standing or walking. So then you tell them that this is how you're going to get stronger, by using these braces, by helping your muscles to get stronger and weight bear on them more. So and then there are dynamic response AFOs that we use. I don't have one of those to show you. They are pretty custom made. They use a lot of different kind of materials. Most of them do have the carbon fiber. The strut is what this is called, the strut, the one that comes here. So in dynamic response, the strut can go anywhere. It can be in the side, it can be behind, it can be front, just depending on what you're trying to control on that patient. And the strut is actually more flexible than this. And it all depends on how the stand stability is, what kind of control you're getting. I have runners who use dynamic response AFOs, and they actually can run in them. But they are really custom made, and because they have to be made in a way where they store enough energy and recoil, resulting in assisting the patient to swing leg forward. So those are very custom, highly custom made, and they're actually over here, they're actually specifically licensed orthotists who actually make those. So you have to call them in and they have to cast them and see exactly what are we looking for, how much tibial translation we need, how much plantar flexion assist they need, how they can walk, how they can run. So a lot of patients who are actually athletes, they use these kind of AFOs. They definitely, so if the strut is able to flex in terminal stance or pre-swing, then it should store enough energy and recoil, resulting in assisting the patient with swinging leg in initial swing. So that is about dynamic response AFO. So this is what they look like. So as I said, they look very different for every patient, just depending on what you're trying to accomplish and what they are needing to do. Also, these are really expensive here too, and not all insurance companies actually cover these. So again, we have to really justify them needing something like this. And these take a while to make too. I think they have to go to a special company over here and get them made. It takes like sometimes it takes like 2-3 weeks to get them. Sometimes I don't have that kind of patience to wait on my patients. I'm like, that's too long. I need to get them walking and doing stuff before, so I'll give them something else for that. If you are trying to, another option that you have, if you're trying to give them a AFO early, you can get something which has the adjustable metal ankle joint. Again, if they have a lot of tightness and you feel like it's going to get better, so say you've given them the night splints and you are seeing some good results with it, you know it's going to get even better and better. And obviously, it is more appropriate for acute patients than chronic patients. Chronic patients, they're hard to give this one, just because the only time I will give them to a chronic patient is if they have a lot of variable girth of the ankle. Say if they have a lot of edema, you're trying to accommodate that, then you have to give them something like this, because this will accommodate the leg swelling on and off, basically. Because if you give them a plastic one and if they get swollen, then they're not going to fit into it. And then if they get shrunk, and if you cast them and they're swollen and they're shrinking, then it won't do the work because it's not snug on them. So this works for chronic patients if you're dealing with leg swelling issues, or it will work for an acute patient where you know the range of motion is going to get better. Do realize, because they have metal joints in them, they get pretty heavy. I would not give somebody really older this brace, because they won't be able to walk in it. It does have the advantage of, early stand stability and early walking. Definitely, because the leg feels heavy, they're able to take weight on that side pretty good. So it'll definitely help you with some forced use on the hemi side. If you're trying to do a hemi patient, again, I would do it more on a younger population, because if they have a little bit extra strength to pick up that leg and walk, or as I said, somebody who has swelling. And then this metal joint, you can see in the picture, you can take an Allen wrench and change the angle. So as they're gaining more and more range of motion, you can change the angle for the tibial advancement better. So that's my spiel on the AFOs that I typically use. They are a lot more, but these are what I use here. I mean, the KFOs, as I talked about, I'm not a big fan of KFOs because they get really heavy to walk with. I would not, you can use them for standing and stuff. And again, if they're younger patients with spinal cord injuries, and they need KFOs, then you'll have to train them with, say, loft strand crutches or regular crutches. So those get heavy to walk with. You can modify the orthotics. Always think about, I actually, once I give them an AFO, I still keep assessing them every at least 3 to 4 weeks to see how much muscle strength they have gained. So that way I can keep modifying them as I need. You can reduce the trim lines. You can actually make, they're called transformers. So you can actually make a solid AFO with the articulated joint. So you can get that made initially, and then you can trim the solid to become a hinged. So you can do those. You can remove the forefoot or shave the foot plate to increase flexibility and preserve some rockers also. So what I'm talking about is you can trim here more. So this typically, if it's a real solid, your foot will actually end before the trim line, before the foot plate is over. But you can trim it further, and that will preserve you at least the third rocker in this one. So you can do all these kind of things if that's what, as they gain strength, and that actually gives the patient a lot of motivation too, that, oh, wow, my AFO is getting shaved off. That means I'm getting stronger. So typically I start with something more invasive like a solid, if that's what they need, and then slowly start trimming it. And that will help the patients also think about, oh, yes, I'm getting better, I'm getting stronger. Some other useful tips I put in there. Again, spasticity is something you really want to consider. So serial casting, PNF stretching, and then always accommodate the range of motion deficits. So if another thing which I use a lot, which actually I forgot to bring, is I use heel wedges a lot. So if you're having issues with knee hyperextension in this, um, so say you've already made this is where the ankle is, and this is how much you're stabilizing their knee, and um, they're still kind of crouching a little, and you don't feel like, actually they're still kind of hyperextending a little, and you don't feel like you want to make this higher, you can actually do a heel wedge. You can put like a 1/2 inch of wedge in here, or you can put a 3/4 inch of a wedge in there to kind of control the tibia, to kind of make the tibia go further into flexion, and that way they don't hyperextend as much, because when they come back, they don't go back further. So I do use a lot of heel wedges for patients who hyperextend. How much heel wedge to use? It's a good question. It does have we actually do have a chart you can use, but honestly, in all practicality, that chart, it takes a long time. So I just have 1/4 of an inch, 1/2 inch, 3/4 of an inch of heel wedges with me. And then I just trial it and see what can control the knee hyperextension better. That's what I typically do. Also, always remember that if you're giving a heel wedge on one side, make sure you are accommodating the other side also. So if you're giving a 3/4 of an inch on left side, do remember then you're going to throw away their pelvic alignment. So make sure you give it on the right side also inside their shoe. If they need more than 3/4 of an inch heel wedge, then I don't put them inside the shoe then I actually get the orthotist to make a wedge on their shoe, like at their sole, because more than 3/4 of an inch is then it gets hard to walk in, because then the foot's already coming out of the shoe. Because you typically have about 2 inches in a shoe where your foot is all the way in. So if you're taking the 3/4 inch of the space away, then you still have about an inch, inch and a half left. But if you go higher than that, then the foot starts coming out and doesn't control the foot so good. So always remember, if you have to go further to control the knee hyperextension, then you do want to get the wedge done outside the shoe. So I think I talked about the heel wedges already. Also, inside shoe lips are the key for contralateral side. You don't want to throw away their pelvis. Also, remember, if you make the stroke side longer, and they have already knee flexion and hip flexion issues, it's going to be harder for them to clear that leg. So always remember that it never hurts to try the wedging or the heel wedge. So if you're not getting the results that you're looking for, and you still feel like the knee is going in hyperextension, or you see some kind of thrust at the knee, try the heel wedge. It actually works really well. They also remember that if their toe plate is not stiff, the heel wedge is not going to work. So the heel wedge will never work on somebody who is has a dynamic brace, because if the toe plate is not stiff, it's not going to push it further. So you want to do the heel wedge on patients who have a solid. Also, in the hinge AFOs, also the heel wedge doesn't work as well. But solids and the plastic PLSs, they actually work pretty good. If you see someone with a good heel contact, but they continue buckling, remember that means you're trying to push the heel really down into the brace. That means the angle is probably not right, because typically if the heel is pushed all the way down in the brace, the knee should not be buckling. So if you have somebody who has a good heel contact, but they do continue to buckle, the ankle angle might be wrong, and you might have to reconsider that. You might want to measure the ankle range of motion and measure what range is made on the AFO, and then go from there. Again, if you see someone with the riding the heel where the heel is not even going all the way down, again, the ankle angle may be wrong. And that can happen. Riding of the heel can happen when they're losing range. So if they're not compliant with their stretching program, if they're not compliant with using their night splints, then yes, the ankle angle will get worse, because they won't go into that much dorsiflexion. They're going to go more and more into plantar flexion. And then the first example where I said where the heel contact is there, but the knee is going and buckling, it could be because they're gaining range, they're doing good things. And so you'll have to reconsider making the brace, or you can consider doing a heel wedge just for a little bit, but as it gets more and more, then you'll have to redo the brace for them. So the other references I've used, as I was saying about this book, the Observational Gait Analysis by Ranchos Los Amigos National Rehab Center. It's a great book. You can use that. And then I did take a course from Elaine Owens. She talks a lot about bracing. She actually has some flow charts on that can help you do the bracing. I have actually attached some of the flow charts here for you all to help. So it's a good algorithm. You can go like, what are you exactly looking for? If there's a problem, yes, no, how to proceed. I think it's a great thing to initially start with and see how it goes. Okay, and that's it. And this is the empty gait analysis form, which I said I was gonna put at the end of the slideshow, so you all can print it out and use it if you need it. So that's all I have. Thank you so much for giving me this opportunity to talk about this. If you have any questions, I'm here. You can email me later too if anything comes on later. And thank you so much, Selvam sir, for giving me this opportunity. It's been a long time since I left Manipal. It's 20 years. So
it's an opportunity for us. It's an opportunity for us to connect with you.
Yeah.
So it is a pleasure having you for this session, and it was a very wonderful session.
Thank you so much.
A very detailed explanation of each of these orthoses. So now before we proceed, we just wanted to take questions from the audience. So participants, please remember to give your feedback. We'll be happy to receive your feedback. So you can just submit your responses. And
so I see a question from somebody here saying that, are you placing the wedge outside the AFO or inside the AFO? You place them outside the AFO. So between the shoe and the AFO is where you place the wedge. If you put inside the AFO, you're actually changing the mechanics of the brace. So you put them outside. Any other questions? Yes, we do serial cast. I actually serial cast a lot of my patients. The biggest problem with the serial casting is their compliance, because if they're not going to follow through it properly, sometimes they come with a wet cast in 3 days. It's really hard in outpatient setting. In serial casting actually works the best when they're inpatient rehab, because they're staying there with you. So it works really well for them. If I do serial cast, I usually keep them they usually come back in 2 days to get it cut. So I usually try it for 2 weeks and see if I'm seeing results. If I see results in 2 weeks, then I'll continue to do them for maybe up to 4 to 5 weeks. If I don't see results in 2 weeks, then I don't continue that.
Yeah, thank you. There is one other question that was posted, but I think the audience is not available. Pavan, Mr. Pavan Garg, he has posted a question.
Sure. What was the question? I can't see it.
No, but but he is not there actually.
Okay.
So he is asking for whether the aspects of pain in the shoulder and neck will be covered.
Oh no, I only picked up the AFOs, the ankle foot orthosis.
So the participants can raise their hands, or alternatively, you can unmute yourself and ask questions. Hi, Aparna. Nice to see you. Good evening.
Hi.
Hi,
Aparna. Hi, welcome to the session.
Thank you. Hi, Anjali. How are you? We were batchmates. That's why both of us are giggling like monkeys.
Yeah. Kavita she is also here.
Yep. Smita's there as well.
Kavita.
Yeah.
I think Deepa is there too.
Yep.
Yeah, I think we are not getting any questions. So, Dr. Shivakumar, do you have any questions? Dr. Shivakumar.
Yeah, good evening, sir. And good evening.
Yeah. Because I specifically asked you because you are working on project related to biomedical devices.
Yes, sir.
Yeah, if you have any questions, please do ask.
Yeah, that is not related to the AFO. That's what I was thinking whether to ask or not. Anyway, I'll ask because she is an expert in the orthosis. Ma'am, what orthosis do you use for correcting the crouch walking in cerebral palsy children?
The ground reaction ones. These ones. The one with the anterior panel. Hold on. The one with the anterior panel. So it'll help you with the crouch walking because it pushes the knee back.
But the crouch will have a problem in the hip, knee, and ankle, right? Then how are you going to handle the hip flexion?
Yeah, so that's what I'm saying. So if you can correct the ankle and if you can help with the knee crouch, then you can keep working on the hips to make the hip stronger. So you don't have to worry about 3 joints. You can at least stabilize the 2 joints in this, and then you can keep working on the hip. The problem with giving them, again, I was talking, the problem with giving them with the KFOs is that they become really heavy for these kids. So typically we don't give KFOs to these kids.
Okay, ma'am. This ground reaction orthosis, will it be that powerful to push the knee back?
Yes, it's very powerful to push the knee back. Yes. So if you want to give it more power, so see how this one has a hole here. So when your leg goes in, you can see the leg. If you need more power, you can actually have the whole front panel. So where there's a whole panel in the front, and that's a lot of pressure to push it back.
Okay, ma'am.
Because with the kids, the problem is that if you give them the metal joints, they get really heavy and they're not that big. So it's a problem. So a lot of my cerebral palsy kids actually have ground reactions.
Okay. That does not have a hinge. That does not have a joint, right?
It doesn't have a joint. No. So that's why you have to keep redoing it, because as they grow or as they get better and better or weaker, you have to keep redoing it.
Are you not arresting the ankle movement? Because you're going to inhibit the muscles, right? Dorsiflexus and plantar flexus.
Right. So that's what I'm saying. It depends on how much control you're looking for, and what kind of safety, like what kind of control they have. So if they have some ankle control, then you can give them a metal ankle joint. Yes. But I will still do a ground reaction on the top if they're crouched.
Okay, ma'am. Right.
So you can do a metal ankle joint, and that way you'll have some flexibility at the ankle.
Okay.
And you can also keep changing the angle.
Okay. And last, one more question.
Yeah, sure.
I have seen some orthosis where you have something in the front of the ankle joint, and there are straps which are extending from there, and then it will be attached to the a strap on the forefoot of the things. There is a control from the front. There is nothing behind the foot. The foot is free.
Oh, you're talking about the one that come in the front just to control, but the foot is free?
Yes. How successful is that? And then why are you all using that?
I am not using that at all at TIRR. I have not used those at all at TIRR.
Okay.
No, I have seen those. I know what you're talking about. And I have talked about that to my orthotist, and he doesn't feel like it's very successful.
Okay.
It's only for people who really need plantar dorsiflexion control, typically. And in my population, I don't see people who have dorsiflexion issues. They're more that dorsiflexors weak, not. So those are used for patients who have a weaker plantar flexors and stronger dorsiflexors. But typically in our population, I've never seen that. It's typically dorsiflexors are weak and plantar flexors are the one that overpower that.
Those are used for the stroke patients, right? Because it is going to take care of the dorsiflexors.
Right.
And then the patient have a power of the plantar flexus, and he can just use it and then they walk, right? That is going to give almost a normal gait, because you have an ankle-free ankle movement.
In the one with the front one you're talking about? But how is it going to pick up your foot if they have weak dorsiflexors?
No, that's an elastic component that is going to pull the dorsiflexion the moment you take it away from the ground.
Okay. I personally haven't. I haven't used that at all.
Okay, ma'am.
So.
Yeah. the thing, ma'am, when you're using a solid AFO,
Uh-huh.
don't you think you're inhibiting the dorsiflexors and plantar flexors?
You are inhibiting dorsiflexors and plantar flexors, and that's exactly what I was saying, that you're inhibiting, but how much do they have functional strength? If they have a strength of 3 anyway to go against gravity, then yes, you don't need a brace. But if they don't have that kind of functional strength, then what are you gaining by letting them walk on a 1-1 plus? Because then they're going to be, their safety is going to be impaired, their balance is going to be impaired. So that's why I was saying you put the brace on only for function, to get them to walk better in a normal motor pattern, to make sure the brain doesn't learn an abnormal gait pattern. Because the problem happens if they start gaining, when they start gaining strength, they can't break their pattern because they've been walking in that pattern for so long with the weak dorsiflexors or plantar flexors, it's hard to break it. So I think for motor control, motor learning, this works really well. You give them a brace, you get them walking, and still you keep working on strengthening. So you can still work on strengthening exercises. You can work on giving them the NMES unit, giving them electrical stimulation to get the muscles working, and then take the brace away as they get stronger. But if they don't have functional strength to walk, then what are we gaining by letting them walk on a 1-1 plus ankle? Because then you're just promoting bad pattern of movement.
Okay, right.
So that's the school of thought that we all follow here, that don't promote bad pattern, because we have seen a lot of patients who don't want to brace themselves. They're saying, no, we're going to get stronger. You're inhibiting our ankle. The exact same thing that you told me. They don't want to do it. And then when they come back 6 months later, yes, they've gained strength, but their brain is so used to walking with that pattern, we can't break it anymore. So now again, they'll still walk in the same hemi gait in spite of them having the strength, because their brain has learned something over a period of time.
Okay, ma'am. Yeah, thank you.
Yes.
Some of our colleagues, I have a startup, I work on medical devices.
Okay.
So we are into developing a kind of a robotic walker for cerebral palsy children. That's in a very initial stages.
Yeah.
There is other colleague who is working on a kind of a programmed AFO. Is computerized programmed. They just take an algorithm and then it synchronized with the gait, and then it automatically does the dorsiflexion and plantar flexions.
Okay.
Have you come across that kind of AFOs?
So we do have something called a rewalk and a locomat. It is similar to what you're saying. It's programmed. You actually put it on the patient, and it does computerized. It's called rewalk, so you can look it up. It's REWALK. That's one of them, and the other one is called Locomat, LOKOMAT. So yes, we do use those in the clinic. We put them on the patient just to program them and train them to walk, so they know when to use their muscles. We also have an electrical stimulation unit called Bioness. It's how do we spell it? BIONESS. So that also, it actually detects your gait cycle. You actually put a cuff on the thigh, you put a cuff around your knee for the dorsiflexors, and then it actually does detect your gait cycle and stimulates the muscle accordingly. So yes, we do use something like that here, but I haven't never given, apart from Bioness, I've never given a rewalk or locomat to take home to a patient, because they get really expensive over here. But they can come to the clinic and try them, and we can keep practicing with them and hoping that they will learn to use their muscles.
Okay, ma'am. Thank you.
Yes.
Yeah, thank you. Thank you, Dr. Shivakumar. So
yes,
we have another question from Mr. Alexander. Is that necessary to wear orthosis AFO throughout life after TA release or metatarsal arthrodesis?
Not really. Not really. If there's a TA release, or actually they should be off their AFOs. If just depending, if that's the only issue that they had, then they should be fused at a place where they can get some kind of ankle clearance. But if they have other issues, like if they have knee contractures or knee weakness issues, then yes. But if it's typically just for the ankles, then no, they should not be wearing an AFO after that.
Yeah, this is actually not a question. Mr. Rishikesh has shared his experience that using of alternate walkers or rollators along with the AFO will help in the alignment of hip in case of crouch gait.
Yes.
So Yeah, so Dr. Shivakumar wants to ask one more question.
Yes, sure. Yes,
Yeah,
we
ma'am,
have
again.
tried physiotaping Aparna with children with crouch gait. It does work well if they don't have too much spasticity we are fighting. If their tone is really high though, I honestly haven't had much success with high tone kids with kinesiotaping. But if they are low tone or if their tone is not that high, then it does work.
Yeah, that question is from Miss Aparna.
Yeah.
Yeah, so Dr. Shivakumar, you can go ahead. Yeah.
Yes, sir. Yes, ma'am. Just on top of ask the same question. What is your experience in treating the children with the crouch walking, and how successful are they? Because we train, and then once the moment when we take them off the orthosis, again they go back to the crouching because their own body weight is acting on them, and then it's a multi-joint involvement, and it's a closed kinematic things, and it is very complex. And we
Right.
were not that successful. What is your experience on that, ma'am?
So that's what I typically do. I start with so stabilize them first, get them a brace that gives them the most stability so they're comfortable walking. See, a lot of times I have kids who don't want to even walk because they don't feel stable walking. So I would start with something very stable, get them walking with the rollator and the walk and the AFOs, and then slowly we can start trimming the AFOs. So don't take the AFOs away right away. That's the biggest problem I think we all end up doing, is you can keep doing their exercises and keep trimming the AFOs and then take them slowly away. And then they do typically good with the rollators.
Okay.
But we don't take the AFOs out like, okay, today they're wearing AFO, you look stronger, we're going to take completely out. We don't do something like that. We actually trim it down. So say if they're not crouching as much, you can trim down under the knee. So like this one, if you had something where you have the whole front panel, you can maybe take away this much away, still leave a little bit on the top for some support. You can trim this more and more to give them less and less support from the AFO.
Okay, right.
Yes.
Yeah,
Thank you.
I think. Thank you. I think Miss Aparna, she has also got something to share. Yeah, can you just share your experience, Aparna, regarding the Pilates with respect to
Yeah,
crouch?
so okay, so not just well, yeah, I've been working with a child for the past couple of years. This is my most recent experience. He has a crouch gait which was quite advanced, so it was a lot of intensive stuff that we were doing. But basically, I've been doing a lot of Pilates with him twice a week, and I've been using the various different equipments, the reformer, the chair. A lot of it is to promote ideal weight bearing. So of course we do it without his AFOs because he needs that sensory feedback through his heels, through the balls of his feet. So we get his intrinsics working, and then just obviously you need to provide him with some support, but just getting him to be in supine, lying on a moving platform, pushing himself back and forth, that works brilliantly because you get your whole patterning in. And what was really interesting with this kid, Anjali, have you seen a reformer before?
I have.
You have, right?
Yeah,
So,
we use it too.
right. So the thing is that you've got the different spring settings, right?
Right.
So the reaction of a lot of these kids, depending on how severe their tone is, the reaction to the different levels of spring settings is really interesting because what we've seen that with a lot of them is that their breathing is so out of whack. They just are not able to produce any proximal stability. If they're not able to produce that proximal stability, they're not able to actually ground their heels sufficiently enough to slide themselves back, which is partly what ends up happening when they stand and they start walking because those springs basically mimic the effect of gravity, right? So getting them to lie down on the reformer, number one, you're putting them into a non-functional environment where their body is like already on high alert and they're trying really hard to focus on something that they're not used to doing, which is lying down and moving, right? Number two, it's a very safe environment, so they're very happy doing it. They're not scared of falling. And number three, it's just fun. I mean, all kids love working on machines, right? So the rate of compliance becomes really, really high.
Yeah.
So very high. So I actually have a few patients who had the financial means to buy a reformer themselves. So what they've done is that They come in, they learn the exercises with me, they go back, they do it every single day with the kid at home, and then we do progression. So we progress this kid from supine into side lying, into being on all fours, into kneeling, into half kneeling, and then finally standing. So it's been brilliant. And I think the most recent thing that we've got out of him is we've managed to transition him onto this other thing called the chair, where we are actually starting to work on his ankle movements, like specifically just getting him to initiate through his toes. There's this thing called the foot corrector and the chair, just getting that little initiation and seeing how that initiation trickles all the way up into the knee and then all the way up into the hip. It's fantastic. It's really fantastic. So yeah.
Thank you so much, Aparna, for sharing your experience. Yeah. Any other questions from the participants? Okay, so I don't see any questions coming from the participants. We have come to the end of the session. On behalf of HOD, Dr. Vaishali, and the team of faculty members of Department of Physiotherapy, Manipal College of Health Professions, Manipal Academy of Higher Education, I profusely thank you, Ms. Anjali, for accepting our invitation. To conduct this webinar session on orthotics in neurological population. So kind of you that you have brought in so many orthoses to show it to us. So it is very nice of you that to explain in detail about each of these orthoses. So at least the audience would have learned, if not full, at least to some extent. So thank you so much, and your final thoughts.
No, thank you so much for the opportunity. It was great to connect with all of you. It's been so long. It's been like 20 years, and I'm glad to see a lot of people here. I'm happy to answer any questions later. I think my email address is on there in the beginning. I think you had put in, sir. So
yes,
you can email me any questions. I'll be happy to answer at the best I can. Thank you.
Thank you so much. So now I'm stopping the recording.
Okay.